Greetings, my name is Corey Langer. I'm the Director of Thoracic Oncology at the Abramson Cancer Center in the University of Pennsylvania in Philadelphia, and it's my privilege today to be joined by Karen Reckamp, Division Director of Medical Oncology at Cedars-Sinai, so a bi-coastal discussion, and in this case of de novo EGFR resistance with a focus on Exon 20. Typically, Exon 20 insertions have represented a relatively small proportion of EGFR mutations. Most are used to exon 19, exon 21 mutations, which constitute the lion's share, easily 90% of all the mutations we encounter. And these patients are exquisitely sensitive to first and now second and third line or third generation TKIs, in particular osimertinib, which has emerged as our standard of care. But for exon 20, the story is very different. Standard TKIs have had very limited activity. Most of these patients exhibit de novo resistance to TKIs. They seem to have worse prognosis, at least when treated conventionally. With rare exception, there are some exon 20 insertions that are sensitizing, but the majority are not. There's been a lot of work, at least retrospectively, looking at the activity of various regimens, with chemotherapy looking, at least through the retrospectoscope, superior to our first and second generation TKIs in this realm. Intriguingly, there are some data from China suggesting that the addition of bevacizumab to chemo in the second line setting may actually yield better progression-free survival than we'd see with chemotherapy alone, or for that matter, with TKIs alone. But for most, the default approach in this population is chemo or chemo combined with an angiogenesis inhibitor. Karen, what's your typical approach for those who have de novo resistance, exon 20 mutation, EGFR?
For patients with exon 20 mutations, generally my frontline therapy is going to be chemotherapy or chemotherapy with immunotherapy, as these patients potentially could have been enrolled on some of the frontline trials as they didn't have activating EGFR mutations.
So presumably some of these folks may have sneaked into the Keynote 189 trial, and probably not 407 since that was squamous oriented, but even 024, 042, because as you said, they did not have mutations exon 19 and 21. It'd be very interesting to see. Are you aware of any data specifically looking at that, or is that just a presumption?
I am not aware of any data that has shown pulled out exon 20 and their responses to immunotherapy.
That would be exciting if somebody could do that, wouldn't it? So I guess what kind of approaches seem to hold promise, or at least some promise, with this type of mutation? Again, I'm talking about those that are inherently resistant, not A763, which could be potentially sensitive to afatinib or even OC up front, but the more common ones.
Yeah, I think this has been a challenging area of investigation, but I think we might be moving towards some viable options for our patients. So the EGFR TKIs, especially the pan-HER inhibitors, have shown some promise. It's always been a challenge to get the therapeutic window and the window of toxicity to meet what these patients generally need. They generally need higher levels of TKI. So probably the furthest along with the most promising data is mobocertinib, with response rates in the 40% range in these patients. And then probably the combination EGFR MET antibody, amivantamab, which also is showing about a 30+% response rate in this patient population. But again, they do reasonably well with chemotherapy, and so these response rates really do have to match what they would do with chemotherapy, because we are dealing with significant EGFR TKI toxicities such as rash and diarrhea that are more toxic than many of the other EGFR TKIs we've used for standard EGFR mutations.
Certainly some of the earlier drugs like poziotinib, and I guess to some extent mobocertinib, featured a lot more GI toxicity, I think, than we'd come to accept with osimertinib in this setting. And certainly, even mobocertinib, the response rate is not on the level in the de novo resistant mutations as you would expect to see with OC, for instance, in exon 19 or 21. We're not seeing 70 or 80% responses. At best, it's about 40%. So I think that's still a major concern. Poziotinib, as I recall, the original response rate seemed to be higher, and then each time it gets presented, the response rate seems to drop off, and I think the most recent one was in the high teens. So again, a bit of disappointment. You did allude to amivantamab, the bispecific antibodies that are targeting both EGFR and MET. Can you expand on that a little bit?
So I think to me, it's a little bit surprising to have a MET EGFR antibody that has activity in an exon 20 mutation, as it doesn't generally have the prior EGFR antibodies did not have significant activity regardless of EGFR mutation. So to have an antibody that has activity in this mutation and standard EGFR mutations with resistance is kind of an exciting thing to look at, and potentially combinable based on the toxicity with other therapies that we have. Chemotherapy, maybe mobocertinib or other TKIs. So I think that it opens up the avenues to other potential therapies. But there are response rates in about the 30 to 40% range.
Which seems promising, at least compared to certainly the first generation TKIs, where the response rates were maybe 10% at best. And apparently better than we come to see with poziotinib in this setting as well. Certainly there's work in acquired resistance looking at lacertinib with amivantamab, and the response rate, at least in that setting, seems to inch up a bit, but I'm not aware of any data yet for lacertinib with the amivantamab, with the bispecific, specifically the exon 20 group. I'm sure that's coming, but I don't think that's been presented. And as you point out, the combination with chemo is probably the most attractive, since chemo is our standard default option, and there is a phase 3 planned looking at standard chemo at pemetrexed with either cis or carbo, plus or minus the monoclonal antibody, the bispecific antibody, and that'll be a big phase 3 trial. To my knowledge, I think assuming it gets completed, that'll be one of the biggest or the biggest trial ever conducted in exon 20. I don't know if you're aware of some other trials, but that should be exciting, and I would think would be accomplishable. Granted, these mutations are fairly rare, but they're not that rare. I think I see more of these than I see certainly c-MET skipping mutations up front. I don't know what your experience has been.
Yeah, no, I think that they're common enough that this trial will get done. There'll be an international trial. And it will be the biggest trial to give us information about chemotherapy and the combination with chemotherapy. So it's a big endeavor, but they should be applauded for moving forward with this.
This has been fantastic, Karen. I think we've reviewed the length and breadth of de novo exon 20 resistance. And again, for all of you who are listening in, thank you very much for your attention.
Thank you.